Hello friends, welcome to INICET May 2024 recall session of Pediatrics. This is Dr. Chandini J from ADRPLEXUS. So hope you have done your exams well. This time almost 18 to 20 questions came from Pediatrics and most of the topics were high yield topics and were repeats. Though we had only few direct repeats, but the topics were repeat. So we'll just go on to those 20 questions and we'll try answering those questions. So first question, insure method is used in the treatment of dash. So insure method. So what is insure method? Insure method is intubate, surfactant administration, extubate. That is insure method. So coming to the options, we have option A, RDS, that is respiratory distress syndrome. Option B, cyanotic spell. C, neonatal jaundice. And D, birth asphyxia. So if you know the full form of insure, you will definitely know the answer is actually RDS, that is respiratory distress syndrome. Okay, so this is a glimpse from our VSV where we discussed about respiratory distress syndrome. So you all know respiratory distress syndrome is seen in preterm babies because of deficiency of surfactant. So here, if you see, they will have a ground glass appearance in the later stages. And the treatment is actually oxygen and CPAP. Along with that, we will give surfactant therapy for certain babies. So if the SpO2, that is FiO2 requirement is more than 40%, then surfactant administration is advised. So surfactant administration is given by these three methods. So first method is insure, that was asked in our question. So what is that? Intubate, surfactant administration, and extubate. Next two methods are called as LISA and MIST. What is LISA? Less invasive surfactant administration is LISA. Minimally invasive surfactant therapy is MIST, where instead of intubation directly, we will less invasive methods are used for surfactant administration. So the answer for the first question is RDS, respiratory distress syndrome. So going to the second question. So this is also a direct question. So the question is, increase in head circumference in the first 3 months of life is it 0.5 centimeter per month, 1 centimeter, 2 centimeter, or 4 centimeter per month? So the answer to this question is, in the first 3 months, the head circumference increases 2 centimeter per month. Okay. So looking at the head circumference, the increases head circumference is in the first 3 months, it is 2 centimeter per month. In 3 months to 6 months, the increase is 1 centimeter per month. More than 6 months till 1 year, the increase is 0.5 centimeter per month. Okay. So what is the normal head circumference at birth? The normal head circumference at birth is approximately around 35 centimeters. So the answer to this question is 2 centimeters per month. Going to the third question. So this is also a question from growth and this is a scenario based question. So the scenario is a 15 years old girl presented with height 145 centimeters, upper segment lower segment ratio of 0.8:1. So what is the likely diagnosis? So first we look at this question. So they say this is a 15 years old girl and 145 is quite on the lower side. So if we plot the growth chart, definitely there will be short stature. And they are telling something about the upper segment, lower segment ratio. So what is that ratio? So upper segment consists of from your occiput, from the vertex to the pubic symphysis is the upper segment. The rest of it is the lower segment. So you will measure the sitting height and subtract it from the total height. You will get the upper segment, lower segment and put the ratio. So this is what we have already discussed in our ESV. So upper segment, lower segment ratio at birth is somewhere around 1.7:1. Around 3 years, it becomes 1.3:1. And after 7 to 10 years, it will become equal, somewhere around 1:1 and 0.9:1. Now, if you see in our answer, in our question, it is 0.8:1. 0.8:1 is actually on the lower side. So it means what are the conditions with less upper segment, lower segment ratio? So when this ratio has to be less, it means that there is some problem with the spine. It means that the upper segment is short. So what are the conditions where the upper segment, that is your spine, is short? Looking at the options, growth hormone deficiency. So please remember, growth hormone deficiency, you will have proportionate short stature. It will not be disproportionate, it will be proportionate. Congenital hypothyroidism, the ratio will be increased. Yes. Skeletal dysplasias. I think the option was somewhere like skeletal dysplasia or spondyloepithelial dysplasia. So spondyloepiphyseal dysplasia. So there also it will be reduced. And achondroplasia, you all know the problem is with the limbs. So the limbs are short, the ratio will be increased. So among these options, the right answer is actually option C, skeletal dysplasia or spondyloepiphyseal dysplasia, where the upper segment, lower segment ratio is decreased. So that is the answer for this question. Okay. Coming to the fourth question. Features seen in child with some dehydration. So we have two questions from diarrhea and dehydration. One was this question and the other question was also from some dehydration. So one was a direct question and single best answer was expected, and the other was a question where multiple answers were possible. So here the question is features seen in a child with some dehydration. So we will look at the answers, options. Increased thirst. Yes, increased thirst is a feature of some dehydration. Lethargy. No. Lethargy, if it is present, you will call it as severe dehydration. Delayed skin pinch. Yes, it will be there. Sunken eyes. Yes, it will be there. So if these three are there, A, C, D, all three are answers for this question. It was a multiple answer question. Okay. So now moving on to the next question, which is also from diarrhea. So here the indicator of diarrhea with some dehydration. So here you have to select only one option. So among these options, which is the best indicator to say that the baby is having some dehydration. So just now we discussed increased thirst is also present, delayed skin pinch is also present, sunken eyes is also present. Among these three, which is the best indicator? Increased thirst. Okay. Because skin pinch will be delayed in both some as well as severe. Sunken eyes will also be there in both some as well as severe. But thirst, in some dehydration, thirst will be increased. In severe dehydration, thirst will be absent. It means the baby will refuse to feed. So that is the differentiating feature of diarrhea with some dehydration and severe dehydration. So in the class and also in the VSP, multiple times I have told you. So when you have a scenario based on diarrhea and dehydration, only look at two things. What are the two things I have told you? One is the mental status, next is the thirst. So some dehydration, baby will be irritable and thirsty. Severe dehydration, baby will be lethargic and the baby will refuse to feed. So these are the key points to identify whether it is some dehydration or severe dehydration. So no dehydration, plan A, where you will give home available fluids. Some dehydration, plan B, where ORS 75 ml per kg is given over 4 hours. Severe dehydration, plan C, where the IV fluid of choice is Ringal lactate. Total of 100 ml per kg we are going to give. We are going to divide it into 30 ml per kg and then the 70 ml per kg. Depending upon the age of the child, the duration differs. This is about diarrhea. So if you have understood diarrhea, you would have got two questions right. Now going to the next question, that is the sixth question. So this is a question from the inborn errors of metabolism, which is an integrated question between pediatrics and biochemistry. So this was the master following given. So all these four, Wongiaki, Pompey's, McArdle, Cory's, all these four are glycogen storage disorders, GSDs. All these four are glycogen storage disorders. So Wongiaki, what is the feature? So Wongiaki is type 1 GSD where the problem is with glucose 6 phosphatase. Okay, this is from VSP, glucose 6 phosphatase deficiency, where they will present with hepatomegaly, lactic acidosis, hyperuricemia and hypertriglyceridemia with doll-like facies. So these are the features which we have already discussed. So Wongiaki, what is it? It is hepatomegaly with lactic acidosis. Next, Pompe. Pompe is type 2 GSD, which is due to acid maltase deficiency, which is also a lysosomal storage disorder. So, Pompe's the right answer is actually glycogen accumulation in lysosomes. So, out of the GSDs, only Pompe is a lysosomal storage disorder. So, Pompe is characterized by floppy infant and cardiomyopathy. These are the features of Pompe's disease. Next, McArdle. So McArdle is what? It is type 5 GSD, where it is present with muscle weakness and something called a second wind phenomenon, where they have easy fatigability to exercise. So the enzyme that is deficient is muscle phosphorylase. So for McArdle's, the answer is actually fatigability during exercise. The last match was Cory's. So Cory's disease is actually due to debranching enzyme deficiency. Okay. So debranching enzyme deficiency is Cory's. Anderson is branching enzyme deficiency. A, B, C, D. Anderson branching, Cory's is debranching. So because of the deficiency of debranching enzyme, there is accumulation of branched product. So the answer for Cory's is branched product accumulation. So this is a question from inborn error of metabolism. So coming to the seventh question. So seventh question is weight for age -2 standard deviation, weight for height -1 standard deviation, and height for age is -2.5 standard deviation. So if you see here, weight for height is somewhat low. It is below -2. I mean, it is exactly at -2 standard deviation. Weight for height is normal. Height for age is -2.5, which is also low. So when weight for age is low, it can be acute, it can be chronic. You cannot differentiate between acute and chronic malnutrition. So it could be acute or chronic. Whereas when the height for age is less, it is what? It is chronic malnutrition. So coming to our options, we have acute on chronic, chronic, moderate acute, and acute malnutrition. So we will rule out acute. Okay. So whatever which has acute is ruled out. So the answer is actually chronic malnutrition. Option B, chronic malnutrition is the answer, because only height for age is reduced. So this is already being discussed in our BSV also. Yes, weight for age is below means underweight. Height for age is below means stunting. Weight for height is less means it is wasting. When weight for age is affected, it could be both acute and chronic. When height for age is acute, it is chronic. When weight for height is affected, it is wasting and it is acute malnutrition. So the answer to our question is actually option B, chronic malnutrition, because only the height for age is affected. So moving on to the next question. The next question was also a direct question from newborn. Downey score includes all except. So Downey score is actually Downey Vidyasagar score, which is used for respiratory distress, to assess respiratory distress. The mnemonic I have told in the class is Kargar. What is Kargar? Cyanosis, air entry, retractions, grunting, and respiratory rate. So here, which is not a component of Downey score? Cyanosis, yes, it is there. Respiratory rate, yes, it is there. Grunting, yes, it is there. But feeding is not a component of Downey score. So the answer to this question is feeding. Feeding is not a component of Downey score. Going to the next question. So the next question is, yes, which of the following vaccine is a conjugate vaccine? It is not a polysaccharide vaccine. Okay. Just let's see. Sorry. So which of the following is not a polysaccharide vaccine? So this is also discussed in class. The options that were given are pneumococcal, meningococcal, H influenza B, hepatitis B. So pneumococcal is also a polysaccharide vaccine. Meningococcal also has polysaccharide vaccine. HIV, previously polysaccharide was available. Now these three polysaccharide was available, but hepatitis B in the class also we have discussed is a recombinant subunit vaccine where the HPS-AG subunit is used. So it is a recombinant subunit vaccine. It is not a polysaccharide vaccine. So the answer is B, hepatitis B. The next question from a very important topic. Every year, without a question from this topic, you will not have a paper. So Kawasaki disease again, which is not a feature of Kawasaki. So if you just see at the options, strawberry tongue, polymorphic rash, purulent, non-purulent conjunctivitis, cervical lymphadenopathy. So if you look at this, so strawberry tongue is a feature. Yes, rash is also a feature. And yes, Conjunctivitis is also a feature. Cervical lymphadenopathy is also a feature. So some of you told that it is purulent conjunctivitis. Some of you told that non-purulent. So I think as all four are options, the options would have been purulent conjunctivitis. So if purulent conjunctivitis was there in the option, then that becomes the right answer. Because in Kawasaki disease, you will have non-purulent conjunctivitis. It is not purulent. So most probably in the question, purulent conjunctivitis would have been given because all the other three are also a feature of Kawasaki disease. So if that is so, purulent conjunctivitis becomes the answer. Okay. So coming to the features of Kawasaki disease. So it is crash burns. So mnemonic is crash burns. C, conjunctivitis, non-purulent. R is rashes, polymorphous rash. A is adenopathy, that is cervical adenopathy, unilateral at least 1.5 centimeters. S for strawberry tongue, and H for the hand and foot edema and erythema. So, and coming to the burns, definitely fever has to be there for 5 days. So these are the features of Kawasaki. So most probably this would have been in the option, and that becomes the right answer. It's 11th question, another repeat topic. Last INICET you had almost 3 questions from parvovirus, and this INICET also had a question from parvovirus. Parvovirus B19 is associated with all except, which is not a feature of parvovirus. Hydrops fetalis, yes, it is a feature of parvovirus. To be specific, non-immune hydrops fetalis. Fever with petechial rash, we are not sure, so we will keep it. Third one is transient aplastic anemia and hemolytic anemia. Yes, it causes aplastic crisis. Pure red cell aplasia, yes, that is also a feature of parvovirus. So by ruling out the other 3 options, we know the answer is fever with petechial rash. Because you don't have petechial rash, you will have a rash that is called as slapped cheek appearance in case of parvovirus B19 erythema infectiosum, where you will have rash in bilateral cheeks, which looks like a slapped cheek appearance. So this becomes the right answer, which is the odd one out of parvovirus B9. So this was discussed, yes. So these are the features of the exact same question was given in TND. See, which is not a feature of parvovirus. It is non-immune hydrops fetalis and not immune hydrops fetalis. Yes. Another topic, that is hemophilia. This time the question is from hemophilia B, and they have asked the treatment options. So treatment options for hemophilia B: cryoprecipitate, factor VIII concentrate, cryopoor plasma, and FFP. So this is a multiple answer question. So cryoprecipitate. So what is there in cryoprecipitate actually? So cryoprecipitate has factor VIII, factor 13, von Willebrand factor, and fibrinogen. So these are present in cryoprecipitate. So cryoprecipitate does not have factor 9. Why factor 9? Because hemophilia B is due to factor 9 deficiency. Hemophilia A is factor 8, but 9 is due to hemophilia B. Okay. So cryoprecipitate cannot be taken as an answer. Next, factor 8 concentrate. Just now I told you hemophilia B is factor 9. So there's no use in giving factor 8. So that is also ruled out. Cryopoor plasma. What is this cryopoor plasma? You remove the cryoprecipitate, you remove these from the plasma, the remaining is called as cryopoor plasma. So when cryoprecipitate does not contain factor 9, definitely your cryopoor plasma is going to contain factor 9. So cryopoor plasma can be used, yes. It's also known as cryodepleted plasma. And FFP, yes, FFP can also be used because FFP has factor 8 and factor 9 also. Okay, so if it is a multiple choice question, 3 and 4 are the answers for this question. Coming to the 13th question, so which is a scenario-based question. A 10 years old boy presents with SMR4, sexual maturity rating 4, hypertension, hyperpigmentation. What is the likely enzyme deficiency? So here it is a male child with SMR4. So 10 years SMR4 is not right because SMR4 is almost corresponds to the adolescent period, later adolescent. Okay. So it means when a child with 10 years is SMR4, it means there is what? Precocious puberty. Okay. Means there is precocious puberty. And what else is there? Hypertension is also there. So this is a case of congenital adrenal hyperplasia. But all of these are causes of congenital arterial hyperplasia. So they are asking you which enzyme is going to deposit. So in our VSV, if you have seen, so you've told which presents with shock, hypertension, and which presents with hypertension. So 21 hydroxylase and 3 beta HSD presents with shock, which is hypertension. So we can rule out those two things. So what are they? 21 and 3 beta are not, because they will present with hypertension. So we are going to rule out that. We are just left with 11 beta and cholesterol side chain cleavage. So looking at our VSV, I have already told you, with hypertension, we have two other enzymes, 11 beta and 17 alpha. So 17 alpha is not there in the option. So 11 beta becomes the answer. So 11 beta is the one which is presenting with hypertension. So the actual answer is 11 beta hydroxylase deficiency. In 11 beta hydroxylase deficiency, the male child presents with precocious puberty. Okay, the male child presents with precocious puberty. So the answer is actually 11 beta hydroxylase deficiency. 14th question. This is also a previous year repeat question. The dose of antenatal steroid was asked. So combinations and permutations of dexa, betamethasone was given. So this is already done in our class also. OG faculty would have taught you this. So coming to the prophylaxis of antenatal steroids, where we give either dexamethasone or betamethasone. Dexamethasone is 6 mg, 12th hourly, 4 doses. Betamethasone is 12 milligram, 24th hourly, 2 doses. So this is the option. Either this or this would have been in the option. You should have selected the right one. Now, what is the advantage of antenatal steroids? So coming to pediatrics. One, it reduces the risk of RDS, that is respiratory distress syndrome, prevents intraventricular hemorrhage. Two more is added in our recent edition of OPCI. Reduces intraventricular hemorrhage, yes, we have discussed. Reduces the risk of NEC, necrotizing enterocolitis. Okay. So reduces early neonatal sepsis. One more, by doing all this, it reduces the NMR, neonatal mortality rate. Okay. So these are the advantages of giving AN steroids. Okay. Going to the next question. This is also a repeat question. Which hormone is not responsible for intrauterine growth of fetus? 4 options were given: insulin, thyroxine, insulin growth factors, and growth hormone. 4 were given. So this was the very first page from our workbook where we have discussed about growth, hormones influencing fetal growth. What are they? Thyroxine, cortisol, insulin. And I have told growth hormone has no role in fetal growth. So what is the answer? It is growth hormone. Growth hormone does not have any influence on fetal growth. Okay, so the answer is growth hormone. Next, there was another direct question on maintenance fluid in children. So in maintenance fluid in children, we usually use DNS. So in DNS, we have 5% dextrose and normal saline. Okay. So this was there in the option. So you would have selected 5% dextrose and normal saline. That is the answer for this question. 17th question. What is not seen in nutritional rickets? Okay. What is not seen in nutritional rickets? So we'll just look at our rickets in VSV. So rickets is, look at the lab features. So you've given calcium, normal or reduced. Phosphate will be mostly normal. Alkaline phosphatase increased. Vitamin D3 reduced. PTH will be increased. Okay. So these are some of the features that you can see in rickets. So calcium normal or reduced. Phosphorus is also normal or reduced. PTH is increased. So these 3 are already given. So by knowing this, yes, this is possible. Normal or reduced, possible. High PTH is also possible. But what about this? By ruling out also, you can answer this. And urine calcium creatinine ratio will not be more, it will be less in case of rickets. So that becomes the answer for this question. Okay. Yes. And there was another question with febrile seizure. So options were somewhere like where you have to select the odd one out, the incorrect statement. Okay. So options were like febrile seizure, the age of onset is 6 months to 6 years. Yes, that is also true. Yes, febrile seizure. For you to say simple febrile seizure, duration should be less than 15 minutes. or only one episode in the first 24 hours. So that was another option. Yes, that is also true. So less than 15 minutes is simple febrile seizure. If the duration is more than 15 minutes or if it is other than GTCS, you call it as complex febrile seizure. And anti-epileptics long-term not needed. Yes, that is also a true statement. Okay. Long-term not needed. Because here we will give only intermittent prophylaxis and not continuous long-term prophylaxis. So all these three are true statements. And there was one more option, not sure of the option. It was somewhat like the recurrence rate is 54%. I'm not sure whether they are given in where the recurrence rate, whether it is in other conditions or whether it is there is any family history of seizure. Nothing was given. Only if recurrence rate is more than 54, then that won't be a correct option because the recurrence rate depends upon certain risk factors. Okay, so in a simple febrile seizure, the recurrence rate is not 54%, it's much less. So when it is given as directly as recurrence 54, then that becomes the odd one out. These three are true statements, so that will become a wrong statement. So if this is there in the option, this becomes the actual answer. So these were some of the questions which I was able to collect. So almost 18 to 19 questions from pediatrics, and most of it were previous year topics. One or two were direct repeats, others were previous year repeated topics. And the slight change in trend was that this time direct questions were more rather than scenario based. Only 2 out of these 18 questions were scenario based. So others were direct questions. So statements were given correct or incorrect was asked, or a direct question was asked. So there was such a slight change in the trend this time. So most of it were almost discussed in our class, and almost 90% of what we have seen today, these 18 recall questions were from almost most of it were from BSP. So if you have studied BSP, you would have easily done all these questions from pediatrics. So hope you have done your exam well. Thank you so much.